Good evening, and thank you for joining us in this session on lung functional imaging. My name is Sam Bayat. I'm a professor of clinical physiology at the University of Grenoble in France. And this evening, it's my great pleasure to introduce two well-renowned experts in the field. Our first speaker is Grace Paraga. Dr. Paraga is professor in the Department of Medical Biophysics and Department of Medicine and School of Biomedical Engineering at Western University in London, Canada. Her team of research biophysicists and clinical collaborators has focused on optimization of pulmonary MRI and CT in severe asthma and COPD. And her goal is to improve patient outcomes by developing imaging tools to more deeply understand the pathophysiology responsible for disease progression, exacerbations, requiring hospital-based care, and to help predict response to novel therapies. So her talk this evening is entitled Pulmonary Functional Imaging, New Ways to Measure Airway Remodeling in Asthma. And before she starts, I'll just remind you that at the end of her talk, you can post your questions on the chat. So Professor Paraga, please.
Thanks very much, Sam. And as I dial up my slides here and fix my multiple monitors, I just wanted to say how grateful I am to you for this opportunity and to share the podium with Jim. So today's talk, well, it's is really going to start from a space that we're all comfortable in, and that's CT of airway remodeling. And I'm going to review some of those biomarkers or treatable traits. Then I'm going to move into a less comfortable zone, MRI of airway remodeling, and review some of the findings, recent findings in that space. I'm going to talk about these measurements from a radiological qualitative point of view and a quantitative point of view using software that many of us have access to. And then I'm going to end with some imaging cases that you might have seen in your clinic or in the hospital, and how we've used MRI and CT to better understand how to manage patient care. So we're going to start here with histology. These are airway histological slides that are stained, and you can see nicely here. I'm going to change my pointer to a red pointer so you can see here that this is a completely collapsed airway, and blown up here you can see the abnormal structure of the airway. And as a reminder, there are 2,400 kilometers of airways in the average lung, so there's lots of room and space for things to go wrong. My argument is that non-invasive imaging can be used to understand these details and airway remodeling. I'll start with CT and move on with MRI. And I start with a schematic here of what airways look like if we could see them in cartoon. A normal airway, one that's plugged with either cellular debris or mucus, another airway where the wall is obviously thickened, constricted, and then collapsed. So if we start with airway plugging or mucus plugging, I turn to the recent JCI paper by Eleanor Dunnican in Dr. Fahi's lab. You can actually see evidence of mucus plugs in the airways that can be measured a great distance. And in our own patients in London, Ontario, what we often see are plugs and then a resolution of the CT airway. And this has become an important feature because, as we know, mucus is a treatable trait in patients with asthma and COPD. These can be quantitatively measured, and they've been shown to be related to sputum to inflammation and airway obstruction. And interestingly, the original paper showed that some of these mucus plugs persist for long periods of time, and I recently heard that they persist at least in the SARP, which is a severe asthma research program that's funded by NIH, up to 9 years. I think we're all very comfortable with the concept of airway wall thickening, and you can actually see this in a CT scan, and I note here severe airway wall thickening in this patient. And again, not only can you see this and visualize it, but you can quantify this by measuring the total area of the airway, the wall area, and the lumen area. And you can see in the schematic that the wall area percent of the total airway would be large. If we move over to constriction, I can focus here on a methacholine challenge, another CT, where you have a baseline CT, the methacholine challenge CT, where you can see the actual airways closing, and then the post-bronchodilator recovery, where the airways open. Again, these can be visualized and quantified. Airway remodeling on CT has been backed up. The sanity check here is that histological studies confirm that when you have a normal-looking airway, you have normal-looking histology, and a thickened airway has absolutely abnormal histopathology of the airway wall. So that's a good anchor for us to focus on here. Another thing that folks have been focusing on recently is airway tree measurements. And as you know, the airway tree in patient CTs, and this is a high resolution low dose CT from my own lab, the dose would be about 1.8 millisieverts. You can actually segment out this airway tree and count the number of terminal branches. And we can actually do this up to the 10th generation, even in a scan like this, to arrive at a total airway count. I noticed, I mentioned that this was piloted and pioneered in COPD patients at St. Paul's Hospital at UBC in Vancouver by that group. Miranda Kirby has published on this topic. And I think it's understandable that in COPD patients, we would see total airway counts that would be reduced. But we were also surprised to see that total airway count, which is the number of terminal branches, and you can visualize that here, where you have thicker number of terminal airways and then a really slim airway tree. We noticed that in a subgroup of 70 patients across a wide scan or breadth of GINA severities, that the actual total airway count, mean total airway count, goes down. These are the 70 patients, and these are some of the measurements that you can make. Total airway count in the mild to moderate versus severes. And if you take a look at that in a little bit more detail, we see that total airway count is reduced in severe asthma, GINA 4 and 5, as compared to the mild to moderate. But I think what's very concerning to me is that even in the GINA mild to moderate types 1 to 3, their airway, total airway count is reduced as compared to healthy volunteers measured in the CAN-COLD study. And in severe asthma, these measurements are actually very similar to what we see in GOLD 2 COPD. So if that doesn't concern you, I think we need to think about why this is happening and how it's happening in asthma. And is this reversible? Because I think many of us think about asthma as a reversible remodeling airway event or mechanism. But if you have airways that are missing, it seems to me that that's not going to be highly reversible. So we asked the question in the lab, what is happening in these airways? Is the wall area thick or is it thin? And this is an important question because in COPD, the folks at St. Paul's showed that the actual airway walls thin out in COPD as those airways become truncated or obliterated. So we went in and measured airways in GINA 4 and 5. And you can see that in GINA 4, where the total airway count is 135, you can see this nice airway, and you can measure the wall area percent, and that's 63%, which is abnormal for sure, but it's much better than in this GINA 5 patient, where you can actually follow the airway out and see it thickened, and then it truncates. So to answer the question, we feel that airway thickening in asthma is what's leading to airway truncation, at least on the CT scans. The airways can also be measured. So we picked a number of candidate measurements and candidate airways to measure. And you can dichotomize the patients by the mean number of missing subsegments in the patient. So if we look at this histogram, we see that many of the patients are missing subsegments. In fact, one patient is missing 20 subsegments, and so on. If you dichotomize them by this number 10, you can readily see that when you have fewer than 10 subsegments missing, you have more normal lumen capacity for air, and you have a much more normal wall area percent. So in summary, this work shows that airway remodeling in asthma is associated with airway termination too. So as we take a step and think about what that means for the patient and what it means for the patients you see in the clinic, we wondered about what are the functional consequences of this kind of total airway count that's abnormal and airway remodeling. And for looking at the functional consequences, we've turned our attention to pulmonary MRI. So on the top panel, you can see 4 patients, and this is a standard proton MRI that you may never have seen before, but there's not much to tell in a standard proton MRI. But when you use and inhale a hyperpolarized gas, which is a polarized gas that's opaque in the MR scanner, you can see these varying degrees of normal, healthy, filled lung, and severity of asthma. As it increases, you can see the increasing abnormality or abnormal images, where the blue is the inhaled gas and the black is actually does not receive gas in a breath hold. And so you can see the increasing severity as you move forward with increasing asthma severity. We and others, including Dr. Wilde's lab, have interrogated these images quite aggressively. This regional heterogeneity in patients is something that hadn't been seen before. And you can quantify, and this is important, these dark holes where there is no gas as the ventilation defect percent. And that's the ratio of the volume of the lung that does not receive that fresh gas, normalized to the volume of the whole lung. So to take on this kind of imaging, you do need a multi-nuclear MR scanner. You do need a polarizer to polarize the gas. And the gas is delivered into a bag, usually mixed with nitrogen or helium-4. We mix it with helium-4 in the case of Xenon to make it more less viscous, and we mix it with nitrogen when we're delivering helium. Different kinds of coils can be used. This is an example of an elliptical birdcage coil, and vest coils are also sometimes more comfortable for the patient, and they fit better, so they can be used as well. Challenges are numerous. The doses in our hands range from $200 to $500, which at least in London, Canada, is on the order of a gadolinium, the cost of gadolinium dose. Access currently is limited to research sites because regulatory approval is needed and underway. I understand that the launch in the US for the clinical use of this research tool is in October of this year. And I think, you know, whenever you're producing new kinds of images and new kinds of data, it doesn't necessarily mean that everyone's going to take notice, because the measurements we provide are very divergent and disruptive. The advantages, of course, is that you get real-time functional information. The measurements are quantitative and relatively effort independent because you just take in a breath. There's high temporal and spatial resolution, so this measurement can be repeated every few minutes. And unlike other MR acquisitions that we're accustomed to, these acquisitions are necessarily fast, because as the breath hold takes place and the scanner acquires the images, the gas depolarizes. So we have to acquire these images in under 15 seconds. And of course, all MRI like this is radiation free, and in our hands, and certainly in the UK and Europe, this is a very safe, well-tolerated procedure. So if we perform a sanity check and we look at these ventilation defects, and I have a square here in a ventilation abnormality and one here in airways that are that are ventilating the lung. The group at Wisconsin looked at the histopathology of what's going on here in these dark holes, and they showed that not surprisingly, the histology reveals a deeply abnormal airway and numerous goblet cells that are mucus secretors. And in regions of normal lung, this is much more normal. But of course, this is an asthmatic, so there are regional differences across the lung in what we can see and what we can't see from a histological point of view. But this is very reassuring that what we're looking at is real. And when you drill down to the microscopic level, it's very real indeed. So now I'm going to talk about remodeling over time, because this is one of the strategic advantages of MRI, is that you can do this over and over again in individuals. And we can do this over and over again over a period of minutes, over days, and over years. And in fact, in our lab and others, folks have been coming back for yearly scans over the period of 7 to 9 years. So I'm going to show you some of these data. This is a patient who has a persistent abnormality here in the right lower lung. It's persistent over 7 years. And this is a patient where they actually have worsening of their ventilation abnormalities over 7 years. So we see both happening. And in this case of the worsening, what I want to point out is this patient had a methacholine challenge at baseline 7 years before, and we did scanning right after the methacholine challenge at PC20, which revealed this kind of fingerprint of ventilation defects. And you can see that at 7 years at baseline, without a methacholine challenge, these are the regions of the lung that are also worsening. So that tells us something about the mechanism of asthma worsening, and maybe it tells us something about how we can avoid this happening in patients. Another point I wanted to bring out is this a similar patient with a baseline and 7-year remodeling. And I've blown this up and co-registered the MRI to the CT. And I'm showing you this airway that leads to this persistent ventilation defect in 3D. And here's the airway that leads to that ventilation abnormality. And you can see that it's a highly abnormal airway. It's actually thinned out and terminates. So I think we can safely say that this airway is probably terminated or truncated or obliterated. And this ventilation defect is probably going to be there for the rest of the patient's life, which is troubling. I'm going to show another couple of cases. Case 1 and case 2 at baseline. You can see the ventilation heterogeneity is different in these two patients, but they're very reproducible in both patients over long periods of time. When we ask them to inhale salbutamol 4 puffs, you can see that this patient actually has a resolution of this patchy ventilation. There's some patchiness that's left, but it's actually very much improved. Whereas this patient shows some improvement, but you can actually see ventilation abnormalities here in the left lower lobes that doesn't go away. Well, what's interesting about them is that this patient has no evidence of sputum eosinophilia when you measure the sputum. So we can probably say that most of what we're seeing is smooth muscle dysfunction. On the other hand, at this time point, this patient had 42% eosinophils in their sputum. And so this led our collaborator, Dr. Nair and Dr. Svenningsson, to move forward with anti-IL-5 alpha treatment. And then after a few weeks of anti-IL-5 alpha treatment, you can see the nice resolution of the eosinophilia and the sputum, and the nice resolution of pre-bronchodilator MRI. So now we're starting to use this, this pattern, this ventilation pattern, to help guide therapy. This is another case in our own lab where we have a 55-year-old female with highly eosinophilic asthma. You can see her FEV1 is very abnormal, ACQ6 very abnormal, SGRQ abnormal, and the blood eosinophils are also abnormal. Post-bronchodilator improvements are marginal, but After 4 weeks of benralizumab, you can see a remarkable resolution of this sort of patchy ventilation. This is a much improved image, a much improved VDP. The FEV1 is remarkably improved, but there's still some remaining pheno inflammation and remaining quality of life improvements that need to happen. But this was a remarkable improvement where imaging helped guide therapy, and it also shows us that there's a response to therapy. On the other hand, this is a 20-year-old female pre and post bronchodilator, a similar story with a miserable FEV1. Blood eosinophils are elevated. She has a post bronchodilator FEV1 that is improved. VDP is marginally improved. And after 4 weeks of therapy, we actually didn't see much of an improvement at all. In fact, I would say that she's just about the same. She's feeling a little better. We didn't have a complete resolution of blood eosinophils or inflammation in the airways. But I want to say that after this patient was on therapy for another 4 weeks, these images resolved completely, and she did get and see a complete improvement in her inflammation. So this is a good example of having to be a little bit patient with the patient and also with the treatment and the biomarkers. So I'm nearly done, and I'm going to talk about this last patient. This is one of the patients that we were about to perform bronchial thermoplasty and asthma. In such patients, we always do MRI to try to understand where the ventilation abnormalities are. And as part of the bronchial thermoplasty protocol that's approved worldwide, there is a 2-day prednisone dose that's given prior to the thermoplasty. And this is a patient without sputum eosinophilia, very poor ventilation, MRI, and very poor quality of life. And yet, we saw, even though there was no evidence of sputum eosinophilia, after 2 days of prednisone, we saw some remarkable improvement in the lung imaging. And this allowed us to identify those regions of the lung that were not prednisone improved, and we targeted them for bronchial thermoplasty. So in general, what we've been doing now is we're using stepwise MRI and CT in these complex severe asthma cases, evaluating them at baseline, post-bronchodilator, and after uses of novel biologics and ICS, OCS. This allows us to think about new ways to help severe asthma patients and our clinical collaborators come up with some treatment strategies. So I'm going to end by reminding you that I talked about some of the main players on the CT landscape as biomarkers of airway remodeling, including mucus or cell debris plugging, wall thickness, and total airway count. And I also talked, mainly in the form of cases, about pulmonary functional MRI. I talked about ventilation defects and their persistence over time, the fact that in some patients they're persistent because the airways have been truncated or obliterated. I talked about the relationship with mucus plugs, asthma control, and exacerbations. There is a relationship, strong relationship with CT airway abnormalities and with histological evidence. I think that in many sites, we can start to use this to evaluate treatment response in difficult patients. And I also think that some of these measurements, CT and MRI, can be considered treatable traits for novel therapies and expensive therapies in N-of-1 studies. So I end by showing you the people who do all the work. We do have our masks on, even our mascot has a mask on, and I thank you so much for your attention.
So thank you very much, Professor Paraga. That was a fascinating, those were fascinating data. And there are already questions from the audience. So one question is, in your data that you showed on the total airway counts, were those in non-smokers, or were also smokers included in the study?
Yeah, that's a very good question. Thank you. And I'm happy to say that all those asthma patients were never smokers. It's troubling to us as to what's going on with these patients. I don't know of another study that shows this kind of airway truncation in severe asthma.
Another question from the audience, from Jesse, is Jesse's asking, how are these ventilation defects actually quantified? And in what units?
So we quantify them in milliliters. We basically measure the total volume of the thoracic cavity that is filled with lung, and we measure that right from the MR, and that's a segmentation, automated segmentation method that many labs have that's standardized. And then we measure the volume of that ventilated gas, and then we basically express the volume of the unventilated regions expressed and normalized to the total lung. And in order to, you can see those images, and they've been, it's clear there are dark areas and there are bright areas and there are in-between areas. And so you can modify your segmentation algorithm to express just the dark areas or the intermediate areas, and you can express them in many different ways. And the field has basically honed in on one method that's very reproducible and very portable.
Yeah, thank you, Grace. Actually, I had a question on the total airway count data that are quite fascinating. I was wondering, so these are airways that can actually be quantified or actually be seen on CT. And do these data suggest that most of the ventilation defects that we see are actually due to conducting airway constriction or blockage? And what is the role of the peripheral airways? Do you see cases where there are ventilation defects without visible, constrictions or obliteration of the, visible conducting airways? Because I always thought that, some of these ventilation defects may be due to small airway constrictions.
It's a real conundrum for us because what we often see are clear wedge-shaped segmental and subsegmental defects. And you really absolutely know that it's attached to that one airway. What we also see in some patients who have very severe asthma is not those archetypal subsegmental ventilation abnormalities or subsegmental ventilation abnormalities. What you see is patchy, very patchy ventilation. And what I'm thinking is that in some patients we see actual blockages or narrowing in some of the larger airways, and in other patients we have actually patchiness that relates more to much smaller airway dysfunction. But we see both, and it seems to be in a continuum that in milder asthma we often see wedge-shaped defects, and I mean it's very obvious where that comes from.
Mm-hmm, mm-hmm. Yeah, thank you. And there's another question asking whether, how do these findings relate to other inert gas methods, for example, multiple breath washout? And have you looked at these relationships?
Yes, thank you for that question. And both Jim's lab and my lab have invested a lot of time in looking at physiological biomarkers like the lung clearance index. Also, oscillometry is a big comparator for us. And what I guess I want to summarize is that there are correlations and there are relationships. I think every measurement has its strength and weakness. In our hands, for example, the lung clearance index doesn't seem to have the dynamic range to capture some of the differences we're seeing with the images because it's such a finite number. People come in with 8 or 7 or 15, but it doesn't have a lot of dynamic range. The oscillometry has been very interesting for us to compare to because, as you know, you can really look at peripheral versus central airway resistances and reactances, and that's more complicated answers to what we're seeing in the images. It's more satisfying.
Thank you very much, Professor Praga. And yeah, I think we have to move on to the next speaker.
Thank you. Thanks.
Thanks. And our next speaker is Professor Jim Wilde. Jim Wilde is Professor of Magnetic Resonance Physics at NIHR, Research Professor in Pulmonary Imaging at the University of Sheffield in UK. His research focuses on the methodology and clinical applications of MR imaging of hyperpolarized gases and protons in the lung and pulmonary vasculature. His research has demonstrated the role of these pulmonary MRI methods in asthma, COPD, cystic fibrosis, interstitial lung disease, lung cancer, and pulmonary hypertension. And in 2015, he and his group have established these modalities as a part of the clinical diagnostic imaging pathway in the NHS in Sheffield. So his talk this evening is entitled Methods for Imaging Gas Exchange in the Lungs using MRI. So Professor Wilde.
Thank you, Sam. Can you hear me?
Absolutely.
Yeah, thanks for the introduction, Sam, and thanks, Grace, for a lovely talk that set the scene for the airways imaging, and it's a great foundation for this follow-on talk. So I'll be talking about how we can image the matching of ventilation and perfusion in the lungs with a view to looking at how we can measure, firstly, VQ matching with MRI, and then also gas transfer using some of the unique properties of Xenon MRI. So if we look at the kind of classical cartoon of gas transfer from John West, V and Q come together in terms of defining how we get oxygen into the lungs of patients. So in terms of patient symptoms, some of the lung function tests we can measure, like the carbon monoxide transfer factor, hopefully we'll get a feel for how MRI can kind of address some of the other side of the equation, that's of perfusion and gas transfer. So typically with MR, we measure perfusion with contrast-enhanced MRI using injected gadolinium contrast agents. So it's a time-resolved method. We can monitor the passage of the contrast through the lungs, through the pulmonary vasculature. We see this bolus passage signal enhancement like this, and from that we can generate parametric maps of perfusion, which is regional blood volume here. And we can also look at the time it takes for the contrast to sweep through the lungs. Here we've got a map of the mean transit time, the mean pulmonary transit time, and that tells us something about the freedom of perfusion and the pulmonary vascular resistance down at the capillary level as well. So here we're bringing the perfusion imaging together with the ventilation imaging. We saw beautiful ventilation imaging previously in Grace's talk. So here we've got the ventilation image. Here we've got a patient with chronic thromboembolic pulmonary hypertension from the Sheffield Pulmonary Vascular Clinic, and there's their perfusion map. If we bring the two together, we get maps of VQ ratio. So this is a VQ histogram presented as an image. There we've got a map of the intersection of ventilation and perfusion. And there we can see the patient's MR angiogram. We can see the occlusion up in the upper right lobe, which is causing the perfusion deficit. So this patient then went and had endarterectomy where the thrombus was removed. And we can see some subtle changes in the lung ventilation, but clearly a big improvement in lung perfusion post-endarterectomy. So that just gives you a highlight of how we can bring the ventilation imaging and the perfusion imaging together to get a better feel for the two sides of the physiological equation, really, the ventilation and perfusion matching. That's the kind of, if we were to do this 10, 15 years ago, we'd have been using scintigraphy. Scintigraphy's still got a role to play in this area, but I think using the MRI, we've got superior spatial resolution and we're also got more functionality. So I'll talk a bit more about that functionality in due course. So that's an example from a patient with CTEPH. Next slide is a patient with asthma. So here we've done a pre and post bronchodilator challenge in this patient. So we have the ventilation images here, and we see this patient's lower lobes were pretty much occluded. Ventilation was restricted. They took their bronchodilator and the bases of the lungs opened up. The airways in the bases of the lungs opened up. If we look at the perfusion imaging, That patient was in a state of VQ matching before bronchodilator. You see down at the bases of the lungs there, the perfusion is basically shut down, and they were in a good situation of VQ match. After the bronchodilator, as I say, the time course of this image, it was done 15 minutes later. The bases of the lungs have opened up with ventilation, but the perfusion has not caught up. So now this patient's gone from a position of VQ match to VQ mismatch as a result of taking the bronchodilator on the time course of this imaging experiment. So we can now get a unique real picture, I suppose, of how to monitor physiological changes with time, both on the V and the Q, using multimodal MRI. So here's just a few examples, really, of in different patient groups of how we've used ventilation imaging and perfusion imaging. Here we've got the percentage of the lung that's ventilated. Here we've got the percentage of lung that's perfused from contrast-enhanced MRI. And we can see by the intersection of the V and the Q, in some groups of patients, like the asthmatics that we've seen in the previous talk, you get good VQ matching, whereas in COPD patients, patients with IPF, patients with lung cancer, the overlap of the ventilation and perfusion is less clear cut. They overlap less. And that's telling us, I suppose, that the ventilation imaging is telling us one physiological aspect of the lungs, whereas the perfusion imaging is not necessarily mapping directly onto what we see with the ventilation imaging alone. So I think it kind of emphasised the importance of being able to do the two, really, and bring the two together to get a better feel for the lung physiology. Here we're just exemplifying a study we did with Novartis. Apologies, I forgot to put a disclaimer slide on. This was a research study we did with Novartis, where we looked at VQ matching in patients with COPD. And we a randomized control study looking at patients on placebo and those on indacaterol. And we see that the patients on indacaterol in this study, their global lung VQ from imaging was improved. And that shows you the perfusion imaging and the ventilation imaging in each of the lobes of the lung. So that's VQ imaging, but we can do much more with Xenon MRI in particular. So if we draw a cartoon of what's going on down at the gas exchange surface in the lungs, we've got the alveolus. So we can ventilate the alveolus and measure the ventilation in the alveolus. We can also, with diffusion-weighted imaging, so this is Brownian diffusion. I'll talk about membrane diffusion next, but with Brownian diffusion-weighted imaging, we can measure the airway dimensions. And that has a bearing on gas exchange. The alveolar dimensions and the alveolar surface area actually defines our gas exchange surface. So being able to measure microstructural changes in the geometry and the size of the airways will in turn give us some information about gas exchange surface. If we now think about xenon gas, it's soluble. So it goes from the alveolar compartment across the interstitium and dissolves in the interstitium. So we get a unique signal from the interstitium from Xenon MRI. And it's also soluble in the red blood cells. So we also get a unique signal from the xenon dissolved in the blood cells. So pulling all that together with dynamic contrast enhanced MRI, we've got a very interesting toolbox for studying gas exchange limitation alongside perfusion limitation in the lungs and applications in various kind of diseases. So I'll talk through some of these. We'll start off just a bit of an overview of the gas itself. So that's the gas polarizer. These are the kind of ventilation images it can generate. The interesting thing about xenon is it's got quite a weakly bound outer electron cloud. And this means that the nuclear magnetic field felt at the nucleus very much changes depending on the environment the xenon's dissolved in. And that means that the frequency it resonates at, the spectroscopic frequency of the xenon, changes as a function of its environment. So I'll come on to talk about that a bit more later on. Starting off, though, let's look at the Brownian diffusion. So here's some kind of comparative images we've acquired. Firstly, with helium-3, that was the gas we all started off imaging 20-odd years ago. Now we're all moving towards xenon because it's more readily available. And as I say, it's got some interesting properties in terms of its solubility. But using what we call diffusion-weighted imaging, we can measure the mean airway dimensions. And here we've got patients with healthy normals, We can pick up preclinical change in airway dimension from the apparent diffusion coefficient related to smoking, and then in end state, late stage emphysema, we see quite elevated diffusivity and increased dimensions of the airways. So we can put quantitative numbers on this. We can map out the mean linear intercept in the lungs using diffusion-weighted models. So now we've got a non-invasive means of kind of mapping the lung histology and the microstructural airway dimensions. We can also look at measuring the radii of the alveoli and also the surface area volume ratio of the alveoli. So it gives us some unique insight into airway dimensions. And historically, this has been used to look at emphysema in the lungs. Recently, we've used these methods, though, to look at IPF, trying to link up what information does it give in terms of gas transfer in IPF. So in IPF, we get kind of fibrosis, sure, but we also get tractional changes in the airways and destruction of the kind of healthy alveolar geometries. So this cartoon kind of highlights that. This is work that we've done with helium MRI, but it's totally relatable to what we do with Xenon MRI. But down here in the bases of these lungs, patients with IPF on the CT, you can see cystic changes, fibrosis down at the bases there, reticulation, these kind of things. In those areas of the lungs, we see hotspots in terms of the mean diffusivity. So the mean airway dimensions are elevated. So what we did in a study, this is a study that Nick Weatherly, who did his PhD with us, has performed with Fung Chan in our group. We monitored the change in the mean linear intercept from diffusion MRI from 0 to 6 to 12 months. And we see an increase, a significant increase in the mean airway dimension of this mean linear intercept from diffusion-weighted imaging. And this is while the FVC and the DLCO, the transfer factor, are both staying sort of non-significant, they're not changing. So we've got a signal there of increasing airway dimension with disease progression that is subclinical. It's not visible on the lung function test. So that gives us a feel for how we can measure airway geometry and airway dimensions that have a bearing on gas transfer. On a patient-specific basis there, we can see individual patients, the direction of travel there for the mean linear intercept, the LMD parameter. Moving on now to the soluble properties of xenon. I mentioned that the resonant frequency of xenon changes as a result of its environment. So here we've got a one-dimensional cartoon of the alveolus. So in a healthy lung, we've got a thin interstitium, a healthily ventilated airspace, and a well-perfused capillary bed. If we inhale the xenon into the lungs, you see good diffusion across the barrier and uptake by the red blood cells. And what we would see is a spectrum, a resonant frequency spectrum of the xenon that looks something like this, with a red blood cell peak and a tissue plasma peak, which were equivalent in size, showing kind of healthy uptake in the interstitium, but transfer of the xenon through into the red blood cells, reflecting the kind of carbon monoxide transfer factor pathway, really. Now, if we look at a schematic of a patient with interstitial lung disease, so here we might have some reduced ventilation, but predominantly we'd be looking at diffusion limitation here, a kind of increased barrier thickness, and possibly some perfusion limitation as well. We'd expect the lung perfusion might be a bit abnormal in patients like this. And what we see there, in this is a patient with quite severe fibrosis, is a very elevated tissue peak and a diminished red blood cell peak. So we've got some possible reduction in lung perfusion, but an increased barrier. So yeah, this is the methodology. We can image these different compartments. So these are the raw images, the images of tissue in the lung, a small gas phase signal because we excite the signal away from the main ventilated compartment. We just need to kind of tickle the edge of that signal to give us a feel for the driving input function, which is ventilation. And then we measured the red blood cell signal as well. We can generate maps of the ratios of these signals. This is a slide from the Duke group, who've then gone and basically segmented out these maps into color coding. So here in a healthy normal, where you've got good VQ matching, and you've also got a thin interstitial barrier, we see good gas transfer. So green is good, green is high, blue is high, red is low. In a patient with IPF with diffusion block, where you've got an elevated barrier, we see a depleted barrier signal and a lower red blood cell signal as well, indicating that the xenon's not getting through into the capillaries as readily. So now we're coming with quantitative parametric maps of xenon in each of these compartments. And these show really nice kind of correlation, these ratios of the red blood cell to the barrier peak in particular with the gas transfer tests. So what we're essentially looking at is an imaging surrogate of the DLCO test, I would say, the ability to monitor regionally regional gas transfer with this methodology. In Sheffield, we've looked at the regional distribution of these ratios, the red blood cell to tissue plasma ratio in the lungs, and in IPF patients in the inferior of the lungs, down where you've got basal fibrosis, we see a depressed red blood cell tissue plasma ratio, and we also see an anterior to posterior gradient in some of these ratios as well. But I think the really interesting thing in terms of IPF, again, is the sensitivity of change of this measurement. So this time it's not a measurement of airway dimension diffusion, it's a measurement of diffusion across the interstitium, the red blood cell tissue plasma ratio from xenon spectroscopy. And here you can see quite a steep rate of change and a clear-cut signal. That signal is pretty much going down in all of those patients with time, with disease progression. If we look at the lung function in this same group of patients, we see an approximate 10% decline in FVC over the whole group, but not much kind of patient-specific change. Whereas, and again, for DLCO, there's no signal. But for the xenon measurements, we're seeing quite a steep rate of decline for most of the patients from 0 to 6 to 12 months, indicating that it's got some kind of real prognostic sensitivity and ability to monitor change. Linking that now to the perfusion imaging, so I'm going back now to the gadolinium DTPA perfusion mapping. These are maps of the mean transit time. This is the time it takes for the perfusion contrast agent to sweep through the lungs. Again, regional sensitivity there. You can see the concordance with CT, pathological changes down at the bases of the lungs where the lungs are heavily fibrosed. It's taking much longer for the contrast agent to sweep through the lungs. And that's telling us that there's microvascular capillary changes there. It's A, there's less contrast agent reaching those parts of the lungs, and B, the contrast agent that's there is taking a lot longer to get through the lungs. Here's some examples of a patient on the top, 2 patients with IPF. One, the mean transit time maps across the whole of the lungs aren't changing a great deal from 0 to 12 months, whereas in the patient below, you would call perhaps a fast progressor in terms of pulmonary vascular disease. That patient's mean transit time is substantially changing with between 0 and 12 months. So again, looking at how that parameter changes with time, we see a significant signal between 0 and 12 months in the mean transit time. That's the full width half maximum mean transit time of contrast agent. Again, in that group of patients, we didn't see a signal in the DLCO, and we saw a 10% change in the FVC, but clear kind of indication there that we've got sensitivity to change. And this is only looking at the global mean average over the whole of the lungs. It doesn't even scratch the surface in terms of what the regional information can tell us. Just looking at the global parameters from MRI, we've got added sensitivity over and above what we see on lung function tests. This is how the 2 parameters shape up against one another. It's encouraging to always look at one imaging biomarker against another, but it's encouraging that here we've got a biomarker of lung perfusion, and we see some good inverse correlation with the xenon biomarker of the red blood cell to tissue plasma ratio. So where we've got high perfusion, where there's a low transit time, so good perfusion generally means rapid passage of the contrast agent through the lungs. The xenon red blood cell tissue plasma ratio is also looking healthy, so to speak. Moving on, we've now started looking at how these different metrics kind of give us a feel for disease progression and at baseline in different subgroups of ILD. So here, this is a study we're doing that's driven by James Eden, who's doing a PhD in our group, where we're looking at different subgroups recruited from Steve Bianchi's ILD clinic. So rheumatoid, hypersensitivity pneumonitis, non-specific interstitial pneumonia compared to the IPF patients. And again, in the IPF patients, visit 1 is 0 and 6 months. We're seeing this progression, but we're not seeing much significant change if you look difference across all of the groups. So all of these groups have got a depleted or a low red blood cell tissue plasma ratio when compared to healthy normals. So a healthy normal ratio will be up between about 0.35 and 0.4. All of these groups of patients have got lower red blood cell tissue plasma ratios when compared to healthy normals. This is some data from the University of Virginia recently published, where they're using these same Xenon ratios, so the red blood cell to the gas signal this time, and the tissue to gas signal, to try and phenotype subgroups of emphysema. So subgroups classified based on healthy DLCO and low attenuating area on CT against healthy normals. So an attempt to try and use this information to better understand and phenotype these diseases where we see abnormal gas transfer. Can the imaging measurements of gas transfer give us some additive information? So that's some interesting work there from University of Virginia. This is some preliminary data from a study that we're doing with AstraZeneca, sponsored research study with AstraZeneca, Rod Hughes at AstraZeneca, as part of the novelty program, where we're looking to phenotype patients who've got asthma and COPD overlap. So spectrum of kind of asthma and COPD symptoms. Here we've got some preliminary analysis from that study looking at how, here we've got the surface area volume ratio from the airway analysis using diffusion weighted imaging, and this is the tissue plasma to gas signal. So if we were to explain this, we'd expect if we've got changes in the gas exchange surface area, reduced surface area volume ratio due to emphysematous changes, for instance, we might expect a reduction in the ability for the xenon to get from the gas compartment into the tissue plasma compartment. So starting to get a feel for how the surface area of the microstructure of the lungs maps onto how the xenon gets into the red blood cells and the tissue in the lungs to really probe regional gas exchange. So excited to see how this study pans out and whether we can actually use this equally to stratify asthma and COPD overlap alongside the CT and the lung function. And just some correlations there with the established lung function tests as well. So this cartoon, again from Duke University, really tries to summarize, I suppose, what these xenon imaging metrics tell us. So ventilation is the driving force. That's how we get xenon into the lungs. But after that, it's a passive process of diffusion, and we see increases or reduction in the barrier signals. And then we also have to look at the effects of the heart and the pulmonary vascular blood supply in all of this as well, because the red blood cell signal is basically driven by the pulmonary vascular circulation, and where we've got pulmonary vascular resistance due to, say, interstitial lung disease down at the capillary level, depending on whether it's upstream or downstream of the capillary, if it's pre-capillary or post-capillary, we'll see a different modulation in this as well. So I'm very interested to see where this technology actually what it can do to help us understand pulmonary vasculopathies as well as kind of fibrotic lung diseases and more classical airways diseases as well, because I think the red blood cell signature from the lungs is going to be modulated quite heavily by concomitant pulmonary vascular disease. So early days, but I think it has got the potential to really help understand these kind of overlapping pathophysiologies of airways disease versus interstitial lung disease, and also the vasculopathy side of things. So just wrapping up, just some early data really that we've done in patients with COVID. So here we're throwing the kitchen sink really at trying to understand what's going on in terms of why have they still got residual breathlessness? We've scanned patients. Here's an acute patient, so you can see with the proton MRI. I would say actually proton MRI is now giving us reasonable structural information. You can see ground glass opacification and signs of residual pneumonia in this patient. This patient was just released from hospital and scanned 2 weeks after they'd been admitted. We see the ventilation scan, so fairly uniform ventilation. We see in the diffusion weighted scan, that's the mean linear intercept, we see elevated diffusivity up in the areas of where there's structural change in the lung, so indicating that there's a bit of perturbation of the airway dimensions in those areas that have maybe become fibrosed or have got residual inflammation. And then the gas transfer map from the Xenon, the red blood cell tissue plasma ratio, again, very depleted, down below 2. That's telling us essentially why these patients are breathless. Basically, there's not enough Xenon getting into their red blood cells, and that's indicating some diffusion barrier blocks still at the interstitial, in the interstitial space, and it also maybe reflects the fact that the perfusion at a capillary level is impeded still. And that again is corroborated by some of the perfusion mapping that we perform in these patients. So linking the absolute perfusion from gadolinium enhanced perfusion MRI to what we see in terms of the gas transfer imaging with the Xenon MRI. So that kind of shows the barrage of tests we've been looking at in these patients. Here's a patient who's acute hospitalized, and again you see uniform ventilation in this patient, but a really reduced red blood cell tissue plasma Xenon ratio image, again indicating that gas transfer is really reduced. And then in a study that we did with the University of Oxford, where we set up the University of Oxford with the same Xenon imaging techniques, there we've been looking at patients who've been hospitalized and have still got residual breathlessness post-COVID. And we see essentially the same things even after 3-4 months later. Patients who are complaining of residual breathlessness have still got a depleted red blood cell tissue plasma ratio in the Xenon MRI when compared to healthy normals. So some insight there into the pathophysiology of COVID as well. Being really where I see this method working is in understanding these patients who've got breathlessness for unknown reasons and getting a feel for how the regional physiology kind of maps onto what we're seeing in terms of the patient symptoms, but also in terms of their global lung function physiology tests. So just as a final slide, 5 years ago, we kind of established this method for clinical utility in Sheffield. We got a license to manufacture the gas from our regulatory body, the MHRA. So we've now basically taken this through the regulatory procedure. My previous speaker mentioned that in the US that same things were trying to be established, but we've kind of broken that barrier really in the UK now, and we take clinical referrals for Xenon MRI now as part of the NHS kind of workup for these difficult cases. We're focusing on trying to make this method as cheap as possible using the natural abundance Xenon isotope and making it work on routine kind of clinical 1.5 Tesla scanners with a view to making it more accessible. So I think that's the challenge for this technique, is now making it more accessible to our colleagues in respiratory medicine so that we can start to use it to answer some of these questions. Big multidisciplinary team, you can't do this kind of research without a group of people that's intrinsically multidisciplinary. These are some of the guys in Sheffield on a relatively sunny day. And I'd just like to thank you all for your attention, and thanks again, Sam, for the invitation to speak at this.
Thank you so much, Jim, for this excellent talk. Fascinating data. Unfortunately, we have very little time for questions. There are many interesting questions. One question from the audience is, Can you do functional imaging in the ICU? Can you sort of miniaturize this? And also comment by Ines Frerix, definitely EIT has its place, electrical impedance tomography as a technique to give an idea, at least do measurements with a high temporal resolution in patients in the ICU, and definitely has its place. Unfortunately, tonight we had restricted time, but I think it should be an effort to organize such sessions again. On your talk, Jim, there are questions about, these are fascinating data on the xenon. There's a lot to say. Are there other gases that you're exploring that would be cheaper or more available than xenon that could be used for ventilation or perfusion imaging?
Yeah. So helium-3 was a gas that is very good for imaging ventilation, but it's not soluble. So xenon, I would say, is really good because it's you can monitor the gas transfer. If all you're interested in is ventilation, I would say that proton MRI has got some good information there. We can map from lung motion. We can come up with maps of ventilation, as indeed we can from CT. But also there's fluorinated gases, so perfluoropropane. This is MR sensitive as well, and that will give a really good image of lung ventilation alone. Again, it's insoluble, so it doesn't measure the gas transfer so well. But if you were to ask me which is the most interesting gas, of course, I think I would say xenon, but it's perhaps also the most, with added functionality comes complexity. So it's now the challenge for us is representing this in more accessible ways, I think, and trying to present the images as maps of physiology is the logical way to go there.
Great. Thank you so much. I think with this, we will close our session. Thanks to all our participants. We had somewhere over 325 attendees, over 700 registered. So thank you so much for being there, and good night.